Hello, everybody. What a great meeting this has been. My name is Eric DeMaria. I'm the immediate past president of ASMBS, and I'm pleased to welcome you to a unique session, at least in my experience. The program chairs, Dr. John Scott and Mona Misra, put together this idea that since ASMBS, like all organizations today, is facing some challenges moving forward, why don't we review some of the history of how ASMBS has faced challenges in the past and emerged with new ideas, new concepts, and new directions for our society to go in. The format for this is interesting. We have 5 talks from past presidents who have had to pivot to deal with problems and then move the society in a different direction. So I'm going to briefly introduce here the people who'll be participating. First, my very valuable co-directors of this session, Dr. Jaime Ponce and Dr. John Morton, past presidents, everyone on this session. And we'll talk with them live after the video talks play. And then we're going to have a talk from 1999 President Dr. Henry Buchwald, from 2003 President Dr. Walter Porres. Dr. Buchwald will be talking about the shift that was made when the NIH refused to do another consensus conference, and he organized one. Dr. Porres will be talking about the beginnings of the Bariatric Surgery Center of Excellence program. Dr. Phil Schauer, who is 2007 president, will be talking about the shift from bariatric to metabolic within ASMBS. Dr. Robin Blackstone will be talking about the 2012 effort to shift towards MBSA-QIP. And Dr. Ninh Nguyen will be talking about the ASMBS push towards board certification. So you can see a good number of very controversial moves that were made by leadership of the society, but with discussion and embracing by the membership too, I think. So with no further ado, we're going to go into the talks and then see you back in about 30 minutes.
Hello, it's my pleasure to be part of this symposium and to discuss the conference of 2004. It was in 1953 that Richard Varco did the first jejunal bypass, the first bariatric procedure. It was 40 years or so later when the first 1991 NIH consensus conference was held, and these consensus recommendations were made guidelines by the NIH in 1998. Now, let's look at this meeting because it's the background for our 2004 meeting. There were 14 panelists, 13 non-surgeons. One surgeon, a Dr. Belugi, who was a retired general surgeon. The speakers were stellar. Brolin, Glaystein, Halverson, Kral, Lanier, O'Leary, Porres, and the late Harvey Sugarman. And what did the conference guidelines say? Non-surgical therapy before consideration of surgery. Consider open, it was only open, gastric bypass or VBG, preoperative evaluation, operation to be performed by an experienced surgeon, post-op lifelong surveillance, and the important criteria that's been quoted ever since 1991, specific criteria for surgery, BMI over 40, or 35 to 40 with high-risk morbid conditions. And this was certified by the NIH in 1998. So, in 2004, the NIH never did a follow-up, and we in ASBS, it wasn't ASMBS at the time, wanted to hold our own consensus conference, and I spoke for the conference in our written, that's why my name's up there. And the purpose was to update the NIH 1991 recommendations. Why? Because there's been an increased incidence of morbid obesity, certainly a tremendous increased incidence of literature on the benefits of metabolic bariatric surgery, evolution of new procedures. We were no longer just doing a gastric bypass and a VBG. Introduction of laparoscopic surgery had occurred, and cost effectiveness was shown. So the sponsor was the ASBS and the ASBS Foundation. What was the role of the NIH? They were invited to hold this conference. They refused. They were invited to participate in the conference. They refused. They were invited to acknowledge and support the conference outcomes. They refused. Now, let's look at who was at that conference and what were the outcomes. Well, the organizer and chief moderator was our next speaker, Walter Porres. The keynote address was done by the Secretary of Health and Human Services, the Honorable Tommy Thompson. There were 25 speakers, 18 surgeons, and again, look at the lineup. Brolin, Champion, Cowan, Flum, Phoebe, Gagney, Hess, Ing, Jones, Kroll, McDonald, the late Ed Mason, Nashland, Pons, Schauer, Scopanaro came from Italy, Shikoro, and the late Harvey Sugarman. And what were our recommendations? A multidisciplinary team approach, pre-op surgical, non-surgical evaluation, but not as a mandatory precondition. Pre-op comprehensive medical evaluation, of course, and we added the current operations that were being done, which included the band and biliopancreatic diversion duodenal switch. And we said we have to be open to future surgical innovations. Standard surgery can be laparoscopic as well as open. Extended bariatric surgery to adolescents. Critical examination, of course, benefit, and increased clinical investigation. And the most, let's say, revolutionary criteria, wasn't that revolutionary, was criteria to allow a BMI of 30 to 35 with a comorbid condition. So in summary, it was essentially an update of the 1991 NIH statement, nothing new or radical, except for BMI 30 to 35. So what was the impact of this 2004 conference? Not endorsed by the NIH, not endorsed by the college, American Heart, ACC, TOS, not actually endorsed by ASMBS, but subsequent statements by ASMBS generally did not even refer to this. They referred back to the NIH 1991 recommendations. There was no stimulus for the NIH to provide new guidelines. And the 2004 panel is rarely quoted. Hardly anybody even knows it ever existed. So in 2013, the NIH was finally persuaded to have another panel review evidence from an obesity expert panel. They took 5 years, 2007 to 2013, when they published their results. They had 23 panelists, and one of them was a surgeon, Bruce Wolfe. Outcomes, they didn't even do anything. They referred the setting of guidelines to the American Heart, American College of Cardiology, and TOS, not to ASMBS or ACS, nothing to do with surgery. And there was no official medical or surgical position taken, no consensus statement, no guidelines. So what did the people who they referred to, the AHA, ACC, and TOS guidelines come out with? They came out with patients with BMI over 40 or BMI over 35 with an obesity-related comorbid condition who have failed behavioral and dietary modification with or without pharmaceutical therapy, may be appropriate metabolic bariatric surgery candidates. And evidence is insufficient to either endorse or encourage surgical intervention for patients with BMI under 35. So a step backwards. And they did not review the, at that time, massive amounts of published material, including randomized trials that showed for a certain cohort with a BMI of 35, this was a life-saving procedure. So what is the status of Metabolic Bariatric Surgery Guidelines 2020 or now 2021? Universally, reference is made by non-surgeons and surgeons to the 1991 guidelines by the NIH. Incremental index adaptations of 30 to 35 BMI have been made by SAGES, ASMBS. If so, based on racial considerations, Asians get comorbid diseases at a lower BMI, and consideration of the literature. There are no current flexible guidelines from the NIH. The consensus conference of 2004 is unrecognized, unremembered, and ignored. And realistic, honest NIH metabolic bariatric surgery guidelines are needed but unavailable. Thank you kindly.
Thank you for the opportunity to talk to you about the history of the Bariatric Centers of Excellence. Let me start some slides here. The question is, how did we get there? Between 1980 and 2000, there was an enthusiastic acceptance of bariatric surgery. After all, look at these drawings. They were finally an answer to obesity, and it was simple operations. Every general surgeon knew how to operate on the stomach, and the results were disastrous. Some hospitals in North Carolina had mortality rates of 10%. And in 2002, when I was the president of the American Society of Bariatric Surgery, I was also the president of the North Carolina Medical Board. That was pretty embarrassing because they showed me the statistics and they said, Walter, you have to do something about this. That's very easy to say, but I didn't have a single idea. So at the 2002 meeting of the society, and never underestimate the power of Southern bourbon. But I met with two guys, good friends, Alan Whitgrove and now the late Ken Champion. And we talked about this. And finally, Alan said, why don't we just let the folks know which hospitals have the good outcomes? It was really a brilliant idea. And at that time, there were no centers of excellence. And we said, great idea, let's do it. But it wasn't that simple. Who would believe the certifications, confirm the data? Who would do the inspections? Even more importantly, who would pay for the costs? And what about the legal side? What about a hospital if it was not certified? We were stopped in our tracks. I really didn't know what to do until I had lunch with a successful business owner in Greenville. He listened to me and he said, Walter, you're talking about a major startup. You need a really successful entrepreneur who knows what he's doing. The best one I know is a guy named Gary Pratt, but he'll never take on something this wild. But I met with Gary Pratt, who had 3 previously highly successful startups. And he made the first curious remark. He said, it's my way to get back to society. And with them, he said, we'll call them Centers of Excellence. And we will found the Surgical Review Corporation. It must be totally independent, unsparing verification with site visits, access to surgeon records. Surgeons are only one part of the system, he said. You also need inspection of hospitals and measure staffing at level of equipment for heavy people, education, administrative support. It'll have to be financially self-sustaining, and there has to be strong legal support. And then, of course, he said, you also need a really reliable real-time data system. And so under his pressure, we developed the Bariatric Outcomes Longitudinal database. It was so real-time that on any single day, you could tell if someone office in Idaho how many people were seen for bariatric surgery and how many of them were hypertensive. With that, this became rapidly successful. In North Carolina, we had 9 hospitals performing bariatric surgery. But once they learned the requirements to be certified, 5 of those closed, leaving only 4 who had good outcomes. There were improvements in training staff. We got equipment to handle the severely obese. And by 2012, this is only 10 years later, we had 476 hospitals and 842 certified surgeons. The American College, of course, noted the success and pointed out that the college had a century of improving quality of surgical services. And said, well, the American College then must include bariatric surgery, and to avoid conflicting standards is that they should be the agency. Stopped us in its tracks, and after some long negotiations between the ASBS and the college absorbed bariatric surgery into NSQIP, but fortunately kept most of the SRC principles and actually applied them to NSQIP. So today, both the SRC and the NSQIP are doing well with continuing improvement in outcomes. The American College of Surgeons has these 8 programs as listed here. In the meantime, the Surgical Review Corporation now has 90 accredited programs with 30 medical and surgical specialties in 30 countries. And it has a tremendous effect. Let me just show you the results in bariatric surgery. Here's the national 90-day mortality for CABG, 2%, colectomy, 4%, routine cholecystectomy, 0.3%. But with the Centers of Excellence, bariatric surgery is now at 0.2%, only twice as dangerous as a normal delivery, in spite of the fact that these are really high-risk patients. So as we look at this Centers of Excellence concept, we must never forget that there's one person who really thought of it and made it happen, and that's Gary Pratt. Thank you very much.
Hi, I'm Dr. Phil Schauer, professor of metabolic surgery at the Pennington Biomedical Research Center in Baton Rouge, Louisiana. I was the very last president of ASBS, and I'm here to tell you the story behind how and why we changed our name from ASBS to ASMBS in 2007. So at my presidential address in 2007, I proposed that we change our name to include metabolic surgery. Now, the truth is, the most memorable aspect of my presidential address was not the name change. It was actually the disaster that ensued when my slides went dark for 45 minutes. And I certainly did get the attention of the audience. In fact, that was my intention all along, was to get their attention, to pay attention to this important proposal regarding the name change. Now, for about 30 years, we were called the American Society for Bariatric Surgery. And since the early 1980s, our organization had changed dramatically. Our numbers grew to more than 3,000 members. Our mission expanded tremendously. We were performing many different types of procedures that were not performed in the 80s. We gained lots of recognition by our peers, but yet there was a sense that the term bariatric didn't completely characterize our field or what we were doing. And there was also a misperception by the public and referring physicians of what bariatric surgery was. So there was a sense that it was time to reconsider our name. So the truth is, several years before, Walter Porres actually proposed that we change our name to the American Society for Metabolic Surgery. Now, at that time, according to the leadership, we were just not quite ready for such a big change. And if you go back earlier into the 1970s, there's actually a textbook called Metabolic Surgery by Henry Buchwald, a former president of ASBS as well. But it seemed in 2007 the time had come to reconsider a name change. And this is because of the evolution of the concept of metabolic disease and metabolic surgery. See, at that time, in 2007, it seemed that obesity and bariatric surgery just didn't adequately represent what these procedures were doing. These procedures were not just causing weight loss, but they were dramatically affecting many metabolic conditions such as diabetes, hypertension, dyslipidemia, the classic metabolic conditions. In addition, we were learning that our procedures had other mechanisms of action other than just weight loss. Effects on gut hormones, for example, were driving a lot of these metabolic changes. So it became increasingly understood that bariatric surgery was an inadequate representation of our field. So at this point, the leadership felt it was ripe for a change, and a variety of different names were actually submitted and discussed and considered. Now, there was an element within our organization, mostly the senior members, who felt that the term bariatric had a long history and a brand name recognition. So many wanted to keep that and perhaps add another descriptor like metabolic to our organization. Now, during my presidential address, I actually proposed this name, American Society for Bariatric and Metabolic Surgery. And shortly after my address at the business meeting, which was a couple days later, there was a hot debate about whether we should change our name, and if so, to what names. And after much discourse by much of the leadership, there became a very strong consensus that it was time to change our name. And the consensus name was what you know today, the American Society for Metabolic and Bariatric Surgery. But I will add that there was strong consideration that at some point in time, as we all became more familiar with the term metabolic, that perhaps it would be appropriate to drop the term bariatric, and that our field would be more accurately represented by metabolic surgery alone. So that's where we are today. And I'll leave it up to the current and perhaps future generations to consider the next generation of the name of our organization. Perhaps we should consider going full course now to the American Society for Metabolic Surgery. And that's the whole story. Thanks so much for your attention.
Hi, my name is Robin Blackstone, and I was the first woman president of the American Society for Metabolic and Bariatric Surgery in 2011 and 2012. During that time, the society was engaged in a very extensive and important debate about how we would move forward with the future of quality in our specialty. And we had some particular issues driving this. The most important one was that the conversation around quality was really changing. And during this period of time, the science of quality, which was really being forwarded by the Michigan Bariatric Collaborative and Surgical Collaborative, as well as the American College of Surgeons, was moving very quickly to understand some very particular issues around quality that the ASMBS really needed to be able to take advantage of. The first of those issues that was really important was that the collection of data had to be very high quality. It had to be done with standardized definitions by people that were reliable and familiar and certified to collect good data. And it had to be abstracted from the record. It couldn't be open to influence by those stakeholders that were part of the group of people delivering care. And all of those issues around data collection were magnified by the fact that the way that the program had been set up from its inception in 2005 was that the burden of data collection really fell on the individual surgical office. And so that really increased the expense and had a potential to impact the quality of the data. When we made the determination, and that was made not only with the full support of the Executive Council, but also after a number of individual town halls, which were very well attended, as well as the publication of a series of articles, you might say white papers, on the nature of quality in our specialty. In fact, you can find those papers published in the quality chapter of the ASMBS textbook, both in the first and second edition. Now, once we decided that we would move to the college, we were able to really elevate the collection of data and to ensure that the payment for the collection of data was really part of the responsibility of the hospital system, which could well afford to do that data collection in the rigorous manner in which it was required. The second really big issue that drove this conversation to a change to partner with ACS in the Metabolic and Bariatric Surgery Accreditation and Quality Improvement program was that we wanted to be able to use the data to inform local quality improvement. In order to do that, and not use data that's going to waste your time doing projects that make no difference to the bottom line safety of the patients you're operating on, you have to do that in a rigorous format. And having that high quality data allows you to take that forward to the local level and through the MBS AQIP quality committee in the hospital to really deploy that data in a way that will change safety for the patients that you and your colleagues are operating on. So that allowed us then to collaborate what is now almost 1,000 programs in the United States alone to really form national collaborative data. And you've seen some tremendous examples of that through the DROP program that Dr. Don Morton championed, through the ERAS program, Energy, that Dr. Stacey Bredhauer championed, and now through the work that Anthony Petrick is doing on using narcotics after bariatric surgery. These efforts and the ability to answer the big questions like anticoagulation after bariatric surgery really are predicated on having high quality data that is collected in a rigorous way that can then be used to inform the specialty and the safety of patients. This entire project was driven by that deep desire that bariatric surgeons have to really provide the safest and soundest quality care to our patients who are at the highest risk of patients operated on in an elective process in the United States. It is very, very impactful program. It was a difficult move to make. There were many aspects of it that were frankly disruptive. But in the end, we have established bariatric and metabolic surgery as the premier quality organization in the United States. Our partners, the ACS, have expanded that effort into so many fields, and we are now part of that bigger collective of the quality conversation for surgery. We were able to really join American surgery by offering such an amazing commitment to high quality care. I'm so proud to be a member of the ASMBS and to have been a part of the team that led that effort.
Good morning. I'm going to be talking about the ASMBS Certificate of Focused Practice Designation in Metabolic and Bariatric Surgery. So currently, all of us has a certificate by the American Board of Surgery. What we'll be discussing today is an additional certificate of Focused Practice Designation, otherwise known as FPD, in Metabolic and Bariatric Surgery. This work is being done in conjunction with the American Board of Surgery. The ASMBS has a representative to the ABS through the GI Surgery Advisory Council. This is a 6-year term. I was the representative between 2012 and 2018, and our current representative is Stacy Brethauer. So the project started in 2012, championed by Dr. John Hunter. And then finally, in December of 2018, the American Board of Surgery requested the ASMBS to submit a proposal for this certificate. Eventually, it made its way to the American Board of Medical Specialty and was finally approved by the ABMS full board in October of 2019. And the news for approval of the FPD was announced by Dr. Eric D. Maria in November of 2019 at his presidential address. So FPD recognized the value that a physician who devote a substantial portion of their practice to a specific area of specialty, particularly in our field, which is the morbidly obese patient population. It also reflects an evolution of practice that occurs following initial certification, and it allows physicians to concentrate their continued certification effort in the very area on which much of their professional practice is based. The difference between an FPD and a subspecialty is that a subspecialty is a body of knowledge or technique in a component of a specialty or subspecialty and requires physicians to complete additional training and pass assessment given by the American Board of Medical Specialty member board. So, for example, a subspecialty would be surgical oncology and vascular surgery. However, a focused practice designation is really an added designation to a certificate. So this would be an added certificate to the American Board of Surgery certificate, recognizing the additional expertise gained through clinical experience. So currently, this is a comprehensive list of the American Board of Medical Specialty member boards with approved FPD. And as you can see, their surgery has only one approved FPD, and that's in metabolic and bariatric surgery. So I'm just going to discuss about the high level of eligibility for this metabolic bariatric surgery FPD. First and foremost, you have to be active in the primary specialty certificate of the American Board of Surgery. 2, meet continuous certification with specific MBS CME credit. 3, you have to complete a minimum of years in clinical practice experience with a focus in metabolic and bariatric surgery, which may include non-accredited training. So meaning that your fellowship training time can be included in this minimum. Next is a lifetime and yearly case volume, and this is done through a case log. Next, you're going to have to practice within an MBS equipped center. And the last but not least is you're going to have to achieve proficiency in a cognitive assessment for metabolic and bariatric surgery, otherwise known as a high-stake examination. So with that, I'm certainly happy to discuss this new certificate. Thank you for your attention.
Great. So I think everybody can see with these talks the rich history that we have in our specialty, and just drawing some observations. I'd like to see these talks archived because they really do deal with significant moments in our history where the society and its membership really had to do the pivot and move in a different direction. I'd also like to point out, if you've been looking at all at the chat, what a vigorous discussion we as members are having in the chat space, which I think really crystallizes what this society is. I've been so impressed with the discussions that are ongoing during this entire meeting. But let me turn attention now to my co-directors for a few minutes. Dr. Jaime Ponce, you were involved as president in 2013, and you really had to operationalize this move towards MBS-AQIP and gain acceptance from the membership. How did that go? How did you manage that?
That is correct. It was a time in which even Georgianne told me that was she hasn't seen a crisis as big as we felt it at that time. So what we did is, first of all, we had long EC meetings, more than 4 hours trying to get consensus on the content and how we're going to approach the recognition of the MBS-AQIP standards. We did a lot of surveys that were well attended and responded in town hall meetings that were also very vocal, and we got a lot of feedback from the members. I also wanted to get the payers involved into this, so we had very frequent meetings. I remember with John and Nin and all the leadership, we met with Blue Cross Blue Shield, Aetna, Cigna, United leadership, to try to help them understand what we're trying to do with quality and accreditation and see if they can include that into their application. And finally, Eric, we did high-stake meetings with the American College of Surgeons to make sure that the content of the new program was based in our membership, meaning that we will have the content and they will provide the resources, the quality resources that they have, which they have a lot of experience with it.
Thank you, Jaime. Great. And if I could turn now to Dr. John Morton, president from 2015. John, one of the things you're known for is going from 0 to 50. And I'm not talking about your car, but rather, the adoption and then universal insurance coverage for the sleeve operation, which obviously is our #1 operation today. How did you help orchestrate and lead that effort?
Well, first and foremost, I want to say that being president of ASMBS was a professional highlight of my career. Nothing tops it. Nothing's better. I'm so proud to be of this organization, proud to be of this panel. And I just want to say that, and I'm looking forward to meetings in the future. We're all looking forward to that. Regards to the sleeve, which is now the most common procedure we do in the United States, it was a total group effort. This was not something that was one individual. Robin Blackstone actually helped start it. We corral support from SAGES, from TOS, from OMA. We had a few things going in our favor. One thing is we had a message. The message was we were safe and effective. We were unified. There was no dissension amongst the ranks. We also were very, very grateful to have all of the different constituencies represented. Additionally, we were patient and persistent. I don't know if people remember when we first put it through to Medicare, we were denied. We did not get a national care determination. They devolved it to a local care determination, and we had a fight to get it approved by all the Medicare administrative contractors in the country. And there were about a dozen of them. So we had to go through each of them, and everybody helped because everybody was a local representative. But in the end, cream rises to the top, and we were able to get coverage for what is now a procedure that we all enjoy performing for our patients. But total group effort. We were working from previous presidents to future presidents. And I'll put in one plug. All of us who are in leadership need to think about that next generation. Let's look out for who's coming up next so we can help them. I know I was tapped on the shoulder by Phil and Robin and so many other folks. So let's keep that in mind. But thank you all for this great, great presentation.
Great comments, John. So now as we try to take this session in the last few minutes to look forward, let me make a couple of observations from the talks and answers that we've heard from the past presidents. One is that I would say there's a couple of themes. One is that repeatedly the ASMBS has led moving forward. And I think that's so important as we look to the future. I would add to the discussion that Nin had about the FPD development that this was not led by the American Board of Surgery. Certainly, we now will be working with them to do this, but ASMBS led on this, and that's why we chose Nin to give this talk, to talk about how he developed the idea that we should pursue board certification. And there was a time when we thought of going rogue and doing it ourselves. Of course, now we're going to remain in the house of surgery for that, which is probably for the better. But in any case, the other observation I would say is that we have been nimble. We've been agile and nimble. We've responded to challenges and moved in different directions, which I think is so valuable. So in the just few minutes we have left, and since we're in a program, an educational event, let's talk a little bit about that. What does the future of the ASMBS education mission look like post-COVID? What do you guys think? Jaime, what do you think?
Well, I think we'll learn a lot from this pandemic, and I think we'll learn a lot that there are more resources, more things that we can do. We can reach to more of our patients. I guess we have another way to improve our follow-up in our patients. Something that we always heard in our papers and our data. So there are things that we learn, and there are things that we can do better. I'm very, very happy how the society has grown, how the society has embraced. I do agree with you, Eric, that this certification is almost completing that circle of recognition from our field. So we don't have to ask now permission to practice. I mean, this is going to be a certificate that is going to give us a full recognition.
And John, thoughts about the future?
Well, I've always been a big believer in mainstreaming. I don't want anybody to put us in the corner. We belong at the table. And one of the things that's really important is to get the attention of the decision makers, which nowadays includes the government. We've been on pause for the last 4 years when it comes to health policy. Hopefully we can have some gains coming up through the efforts of people like John Scott and Joe Northup. We're going to get that obesity pact working for you. But I think education needs to start there. We need to educate the society. What we do is safe and effective and should be applied to all in need. That's what needs to happen.
Phil, any comments on the future education mission?
Well, sure. I mean, Eric, we've all been faced with this great COVID crisis, and often in a crisis, there is a silver lining. And if there is a silver lining for COVID, is that it has shed more light on obesity as a very serious, deadly disease. Folks who have obesity are more likely to get COVID because of their impaired immune system, and they're much more likely to have a severe outcome. So hopefully, this is going to draw a lot more attention to government agencies, NIH funding, to focus more on the biggest public health crisis of our time, the other pandemic, which has been going on for 30 years, and focus more resources and more attention on addressing obesity.
Great comments. I think we're going to need to wrap this up and move to the closing remarks. I'm told that there's another session that you go through the agenda to actually get into that room so that we can hear from our program chairs, Dr. John Scott and Mona Misra. What a phenomenal program. I get to say that as we move to that session, but this has been a great session. I've learned a lot. I really appreciate everybody's participation, and hopefully we'll see each other soon in person in a real meeting.
We'll see you, I guess. Bye.
Thank you.
Great program, guys. Fantastic. Congrats to all.